Respiratory case is quite simple when it comes to case perfoma. All we have to do, apart from normal general examination, is that we have to know about history of presenting illness thoroughly, especially the cough part and the dyspnea, wheeze part. All this definition and causes, be thorough with it. And we have specific examination in systemic examination, wherein we examine respiratory movement, dimensions or the measurements of the chest, vocal frequencies. Then we have percussion. Then we have breath sounds, vocal resonance, adventitious sound. So to begin with, RS case, let's start. History taking, as usual, name, age, sex, address, occupation, date of admission, date of examination. Then we'll begin with chief complaints in a chronological order, whichever is appearing first should be in the first. That is, some symptoms which appear 6 months ago will be in the first, and the ones which appear 2-3 days ago will be in the last, according to that chronology. Then in HOPI, in RS case, we have major symptoms such as cough, expectorations, hemoptysis, dyspnea, chest pain, wheeze. So when you look at this, you have to study each of them individually, and there are other set of questions which you have to ask for the patient, such as duration, onset, progression, aggravating factor, relieving factor. These are set of general questions you should know. Don't miss to mention it in your history case. And to rule out other diseases, we have to ask few more history, such as nasal discharge, recurrent cold, epistasis, headache, weight loss, anorexia, evening rise of temperature, smoking, belching, regurgitation of food, hoarseness of voice. So once we are done with HOPI, we have to speak about past history, such as asthma, COPD, TB. These are very significant past history, especially in a respiratory case. Ask this without fail in detail. Then we have the usual ones, such as diabetes, hypertension, ischemic heart disease, seizures. Then moving on to family history, draw 3 generation pedigree. Then we have personal history, such as diet, vegetarian, mixed, or appetite, good or reduced, sleep sound or is it disturbed, bowel and bladder if it's normal and regular, or if it's not. Habits such as smoking is very important in a respiratory case. Without fail, you have to mention smoking index. So we have alcohol, tobacco chewing, and allergy history. So moving on from here, drug history, drugs used at what frequency and what duration of time. To summarize main positive findings, you have to get a proper history of presenting illness and summarize the main positive history, write few differential diagnoses at this point. Then we have general physical examination. So and so year old male patient or female patient, moderately built, nourished, conscious, cooperative, well oriented to time place person. Check vitals, pulse, rate, rhythm, character, wall thickness, if any radial or radiofemoral delay. Then we have BP arm. Then we have respiratory rate, if it's irregular or regular, if it's thoraco-abdomen or abdominothoracic. Then we have JVP and pulse oximetry. Then moving on to general physical examination, pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema. As we know, pallor in respiratory case is as important as clubbing. Clubbing is more important than pallor. In clubbing, you need to be thorough with the causes, especially bronchogenic carcinoma, bronchiectasis, emphysema, then abscess, asbestosis, cystic fibrosis. After examining this, we have BMI, and we have to examine other things, such as signs of respiratory failure, features or accessory muscles of respiration used or not, or any external markers of TB or malignancy. From here, we have systemic examination. Systemic examination, the upper respiratory tract includes nostril, nasal septum, nasal polyp, sinus tenderness, tonsil, posterior pharyngeal wall. Without fail, mention this in your case chart. Then we have lower respiratory tract examination, inspection, shape and symmetry of the chest, then spine, then subcostal angle, any deviation with trachea or a apex bit. And on inspection, look for respiratory movement, upper anterior chest respiratory movement, and similarly the other chest movements. Palpation. Rub palms before you palpate, uh, because to warm your palms. Look at the spine position, trachea, apex. Then we have respiratory movements. Divide it into areas, measure it equally simultaneously on both sides. uh, and since it is inspection, it's not necessary, but when it comes to palpation and percussion, you have to do it simultaneously on both sides. So you can look at the areas of supraclavicular, clavicular, mammary, suprascapular, infrascapular. Then we have dimensions, and anterior posterior transfer diameter is must when you do a respiratory case, and chest expansion, chest circumference, do it simultaneously. Then we have vocal fermitus, uh, and after vocal fermitus we have percussion. Percussion, be thorough with steps. They'll definitely ask you about pleximeter and so similar questions related to it. Then next, auscultation, breath sounds. Look at all the areas simultaneously on both left and right side. Then we have vocal resonance. Look at both the sides simultaneously. And finally, we have adventitious sound such as rhonchi crepitation rubs, and additional tests such as shifting dullness or coin test. After everything is done, make sure you mention the other systems, CVS, CNS per abdomen. Then finally, done with summary. Be specific in summary. Don't miss any examination findings. Then write your differential diagnosis. And with that, you complete a respiratory system case presentation.